This presentation is provided through a shared commitment between Access, Health Current, and Myers & Stoffer to increase participation in the Medicaid Promoting Interoperability, or PI program. A few logistic reminders. Today's webinar will be recorded and posted to the Health Current and Access websites. Please use the chat box for questions or comments. Please include your name, practice organization, and do not include any confidential information such as patient health information or PHI. All lines will be muted, and I will now pass the ball to today's presenter for the Stage 3 Meaningful Use webinar for program year 2019.
Thank you, Christine. This is Connie Ida. I'm Program Director for Health Current. Good afternoon to all of you on the phone, and thank you for participating in today's webinar. Patricia Clark, as Senior Accountant for Myers & Stoffer, a certified public accounting firm specializing in federal and state Medicare and Medicaid programs, is our webinar presenter today. So with no further ado, Priscilla, Christine has now enabled you to share your screen so you can begin your presentation.
Thank you, Connie and Christine. Good afternoon, everyone. Today's webinar, as has already been stated, will cover program year 2019 Stage 3 MU requirements. So the Stage 3 learning objectives. The first learning objective is to understand the Stage 3 requirements for the Medicaid Promoting PI program. Understand the differences between the program year 2018 modified Stage 2 and program year 2019 Stage 3. And the last thing we will be learning today is the Stage 3 documentation requirements. Meaningful use, the HITECH Act description. The Recovery Act specifies the following three components of meaningful use. The first component is use of Certified Electronic Health Record Technology, CEHRT, in a meaningful manner. The use of a CEHRT for electronic exchange of health information to improve quality of health care. And the last component is the use of CEHRT to submit clinical quality measures, otherwise known as ECQMs, and other such measures selected by the Secretary. Meaningful use health outcome priorities. To improve quality, safety, efficiency, and reduce health disparities. To engage patients and families in their health care. To improve care coordination. To improve population and public health. And to ensure adequate privacy and security protections for personal health information. Let's go over the different requirements for meaningful use. And please keep in mind that this PowerPoint presentation will cover the MU requirements listed on this slide. However, EPs must still meet all eligibility requirements of the program. And to learn about those eligibility requirements, you can use the link at the end of this slide. Beginning in 2019, all EPs are required to attest to Stage 3 of MU. All EPs must have 2015 Edition CEHRT. There are 8 objectives, and the related measures must be met. 5 of those objectives are percentage-based measures. 3 of those objectives are yes-no measures. If exclusions are selected, the EP must meet the exclusion criteria. The EP must report on a minimum required number and type of ECQM. The EP must maintain at least 80% of all unique patients' data in CEHRT. And the EP must perform at least 50% of all encounters at locations with CEHRT. So for program year 2019, we're going to go over the different types of periods and how long they have to last. For the PI reporting period, it must be 90 days for all EPs. The PI reporting period must be inside calendar year 2019. The ECQM reporting period, so this is going to be a second reporting period that each EP will have. That reporting period is 90 days for EPs attesting to their first year of MU. The ECQM reporting period is 365 days for EPs that received an MU payment in a previous year. The ECQM reporting period must be inside calendar year 2019. Here are a few examples that we will go over of the different reporting periods and whether they are sufficient or not to help you understand how the length of each period. For the first example, the EP is in payment year 2. The meaningful use year is their first meaningful use year. And the PI reporting period is September 1st to November 29, 2019. That's a 90-day period, which is sufficient. Now, the ECQM reporting period for this EP, because they're in their first MU year, is September 1st to November 29, 2019. This is sufficient because it's a 90-day period and the EP is in their first MU payment year. Now, for the second example for the EP, they are in their payment year 3. However, they are applying for their MU year, their second MU year. Their 90-day period for PI reporting is September 1st to November 29th. Their ECQM reporting period, however, is only 90 days, which is not sufficient. September 1st to November 29th. The last example, payment year 4, the EP is attesting to their third MU year. The PI reporting period is 90 days, and the ECQM reporting period, as you can see, is for the entire 2019 calendar year, which is sufficient. This EP, because they're in their third, or even if they're in their second, fourth, fifth, or sixth MU year, they must attest to a 365-day ECQM reporting period. Another requirement is the 2015 Edition CEHRT. EPs must use 2015 Edition CEHRT beginning in program year 2019. The 2015 Edition CEHRT did not have to be implemented on January 1st, 2019. However, the CEHRT must be implemented by the first day of the PI reporting period. The CEHRT must be certified by ONC as a 2015 Edition product by the last day of the reporting period. For example, the 2015 edition may have been implemented by the practice before the start of the PI reporting period, even though the product is still pending ONC certification. However, that certification must be approved by ONC by the last day of the PI reporting period. You can look at the ONC website to learn when various CEHRT products were certified. Documentation for 2015 Edition CEHRT. The EPs must be using that 2015 Edition CEHRT beginning in program year 2019. The CEHRT documentation should include the date the 2015 Edition CEHRT was implemented, the edition number, and the practice name. Some examples of these are CEHRT contracts or vendor letters. Another requirement of the program is that EPs must attest to 6 out of 50 available CQMs. 6 of those 50 outcome measures, 27 of those CQMs are high priority measures, and there are 17 remaining measures. EPs must first focus on this first priority level, on priority level 1. If relevant, at least one ECQM should be an outcome measure. However, if none of the 6 outcome measures are relevant to the EP, they should move to priority level 2. If no outcome measure is relevant, at least one ECQM should be a high priority measure. So as you can see, priority level 1 should be attempted to be met first by the EP. But if those CQMs are not relevant, they move to priority level 2. And in that scenario, the one ECQM should be a high priority measure. However, if no outcome or high priority measure is relevant, they should move to priority level 3 and report on relevant measures if possible. As you can see, there's a link at the bottom for the Clinical Quality Measures webinar that was presented by Access and Health Current at the beginning of this year. And it walks you through even more details about clinical quality measures and the requirements. Documentation for CQM. You must run a CQM report from the CEHRT for the appropriate reporting period. You must prove that the ECQM data was calculated by 2015 Edition CEHRT. Some examples of that to prove that is the report must show the CEHRT name or screenshots demonstrating how the report was pulled from the CEHRT. The report should include the following: the required number and type of ECQM, the numerator and denominator for each ECQM, the most recent ECQM version the CEHRT has available, and the proper reporting period. So keep in mind, there's for different EPs, depending on what MU year they are in, it can be 90 days or 365 days for the reporting period. So general requirements. The EP must maintain at least 80% of all unique patients' data at locations with CEHRT in the CEHRT. The EP must perform at least 50% of all encounters at locations with CEHRT. EPs who practice in multiple locations must have 50% or more of their patient encounters during the PI reporting period at a location or locations equipped with CEHRT. Now let's discuss the documentation requirements for that. The EP should submit a detailed encounter listing for the reported 90-day PI reporting period in Excel containing the following fields: the patient name or unique identifier, the date of service, the date of birth, the location name where that patient was seen, and identify which patients do not have data maintained in the CEHRT if they were seen at a location that has CEHRT. So we're going to be referring to a lot of different documentation documents throughout this presentation. So here are just some definitions of the different types of documents that may be required for different measures that are met by the EP. So there's first the standard documentation. There are two types of standard documents that we will be referring to throughout this presentation. There is going to be the yes/no standard documentation, the percentage-based standard documentation, and then we may request additional documentation, which is when the EP must submit the standard documentation and the additional documentation listed. The last type of document is the alternate documentation. The EP has the option to submit alternate documentation in lieu of the standard documentation. This is a general overview slide. We will go into more detail about these measures in later slides, but this lists out all the different 8 objectives. It gives you the name for each objective. In the third column, it gives you the type of measure. Is it a yes/no measure, or is it a percentage-based measure? The fourth column identifies the documentation requirements. As you can see, we've referenced percentage-based standard for Objective 2 for electronic prescribing. The last column is additional resources for other webinars that have been presented by Access and Health Current to help you learn more of the details behind each of these objectives. An in-depth webinar for these measures, for different measures, are planned for 2020. Specific dates to be announced at a later date. As you can see, for Objective 1, Protect Patient Health Information, there is an SRA webinar that has been previously presented that you can go into to see what specific requirements fall underneath protecting patient health information. So standard documentation. Let's talk about the percentage-based measures for standard documentation. Unless otherwise specified, you will need to submit the CEHRT dashboard for all percentage-based measures. The CEHRT dashboard should include the following: reflect the correct PI reporting period, include the provider name, reflect all percentage-based measures, and it should match the attestation. If attesting to an exclusion for a measure, the CEHRT dashboard may be utilized to support meeting the exclusion criteria for certain measures. If exclusion is not supported by the CEHRT dashboard, additional documentation is required. Now, the standard documentation for yes/no measures. The CEHRT dashboard alone cannot be used to support these measures. Documentation should include the following: a screenshot from the CEHRT or a vendor letter to support the applicable functionalities were enabled or the actions required were performed. The documentation should show the following: include the provider and/or practice name as applicable, reflect results for the measure, be clearly legible, and reflect the date the requirement was met. And on the next slide, we talk about the different date requirements for the yes/no measures. Security risk analysis for Objective 1. The SRA must be completed on or after the end of the PI reporting period and no later than December 31st, 2019. For clinical decision support rules and drug-drug and drug allergy interaction checks, it should show the date the requirement was met during the PI reporting period. So make sure your documentation for this measure shows a date during the PI reporting period. For public health measures, the documentation should reflect the date within 60 days of the start of the PI reporting period. Please keep in mind that EPs that completed registration in the previous year meet active engagement option 1 if documentation is dated from the previous year and shows that they meet active engagement option 1. So let's go into each of those 8 objectives. The first one is protecting patient health information. The objective is to protect electronic health information created or maintained by the CEHRT through the implementation of appropriate technical, administrative, and physical safeguards. The measures to conduct or review a security risk analysis in accordance with the requirements under 45 CFR, including addressing the security, which includes encryption, of data created or maintained by CEHRT in accordance with the requirements under 45 CFR regulation. and implement security updates as necessary and correct identified security deficiencies as part of the provider's risk management process. There are no exclusions for this objective. A security risk analysis should contain a layered approach and be dated appropriately. Although there is no specified method that guarantees compliance, there are several elements a risk analysis must incorporate regardless of the method employed. It should contain asset inventory. It should contain physical, administrative, and technical safeguards, including encryption to electronic PHI. It should identify threats and vulnerabilities. It should determine the likelihood of threat occurrence, the potential impact of threat occurrence. It should determine the level of risk, and it should have a remediation or action plan. And as a reminder, you can look at the SRA webinar that covers the SRA requirements in depth. Let's talk about the date for the SRA. It must be completed on or after the end of the reporting period and no later than December 31st, 2019. The SRA must show the date completed. There are a few examples of what an appropriate dated SRA is for the different PI reporting periods. For the first one, if a EP has a reporting period from January 1st to March 31st, 2019, they can complete their annual SRA and date it anytime between March 31st and December 31st, 2019. If you go to the very end, you'll see for the last example, if the EP has a reporting period October 3rd through December 31st, 2019, the annual SRA must be completed December 31st, 2019, because it must be completed on or after the end of the PI reporting period and no later than December 31st. There are no other appropriate dates if that is your meaningful use period. For Objective 2, electronic prescribing. The objective is to generate and transmit permissible prescriptions electronically. The measure is more than 60% of all permissible prescriptions written by the EP are queried for a drug formulary and transmitted electronically using a CEHRT. The exclusions for this objective. An EP may take an exclusion if any of the following apply. If the EP writes fewer than 100 permissible prescriptions during the PI reporting period, or does not have a pharmacy within their organization and there are no pharmacies that accept electronic prescriptions within 10 miles of the EP's practice location at the start of his or her PI reporting period. So documentation for this measure. The percentage-based standard documentation is required, and you can look back at slide 17 to see what things on that document should be showing on the standard documentation. The exclusion documentation. If the EP meets the first exclusion, which is writes fewer than 100 permissible prescriptions, the standard documentation would be required. The CEHRT dashboard showing that the EP wrote fewer than 100 permissible prescriptions during the PI reporting period. However, there is an alternate documentation that can be submitted if the EP chooses to. Please keep in mind that the standard documentation might be appropriate to meet the exclusion. However, the EP can choose to submit alternate documentation that demonstrates the EP has fewer than 100 permissible prescriptions. The second exclusion is no pharmacy within the organization or within 10 miles of the EP practice. Additional documentation should be submitted and will show the closest pharmacy to the practice at the start of the PI reporting period. The EP should demonstrate how they determined no pharmacy is within 10 miles of the practice. Objective 3, clinical decision support. The objective is to implement CDS interventions focused on improving performance on high priority health conditions. There are two measures underneath this objective. Measure 1, implement 5 CDS interventions related to 4 or more CQMs at a relevant point in patient care for the entire PI reporting period. Absent 4 ECQMs related to an EP scope of practice or patient population, the CDS interventions must be related to high priority health conditions. Measure 2, enable and implement the functionality for drug-drug and drug allergy interaction checks for the entire PI reporting period. Exclusions for this objective. For Measure 1, there are no exclusions available. For Measure 2, an EP may take an exclusion if the EP writes fewer than 100 medication orders during the PI reporting period. Let's discuss the documentation required for CDS. The standard yes-no documentation for both measures should be submitted, and you can look back at slide 18 that explains the requirements for standard yes-no documentation and what we look for. Examples of supporting documentation to meet this measure are included in the documentation retention webinar link found on this slide. For the exclusion documentation, please keep in mind that there is no exclusion available for Measure 1, so this is only applicable for Measure 2. To claim the exclusion, the EP must write fewer than 100 permissible prescriptions. The standard documentation can be submitted, which is the CEHRT dashboard showing that the EP wrote fewer than 100 medication orders during the PI reporting period. However, the EP does have the option to submit alternate documentation, and that alternate documentation should show that the EP has fewer than 100 medication orders. For Objective 4, computerized provider order entry. The objective is to use CPOE for medication, laboratory, and diagnostic imaging orders directly entered by any licensed healthcare professional, credentialed medical assistant, or a medical staff member credentialed to and performing the equivalent duties of a credentialed medical assistant who can enter orders into the medical records per state, local, and professional guidelines. An EP, through a combination of meeting the thresholds and exclusions, must satisfy all three measures for this objective. Measure 1 is the EP writes more than 60% of medication orders created by the EP during the PI reporting period are recorded using computerized provider order entry. For Measure 2, more than 60% of laboratory orders created by the EP during the PI reporting period are recorded using computerized provider order entry. More than 60% of diagnostic imaging orders created by the EP during the PI reporting period are recorded using CPOE. An EP may take exclusion for the appropriate measures. If, for Measure 1, an EP writes fewer than 100 medication orders during the PI reporting period, for Measure 2, the EP can take the exclusion if the EP writes fewer than 100 laboratory orders during the PI reporting period. And for Measure 3, the EP who writes fewer than 100 diagnostic imaging orders during the PI reporting period may take an exclusion. The documentation for CPOE. The standard percentage-based documentation should be submitted to meet the requirements for this objective, and you can see slide 17 for the details behind what should be shown on the percentage-based standard documentation. The exclusion documentation the exclusion can be taken by the EP who writes fewer than 100 orders for the applicable measure. The standard documentation is an option for the EP to submit to meet the exclusion. The CEHRT dashboard shows that the EP wrote fewer than 100 orders for the applicable measure during the PI reporting period. However, if the EP does not want to submit the standard documentation, they can submit alternate documentation, which is a document other than the CEHRT dashboard that demonstrates the EP has fewer than 100 orders for the applicable measure. Please keep in mind that the EP must submit either the standard documentation or the alternate documentation to meet the exclusion for this objective, but they do not have to submit both. For Objective 5, patient electronic access. The objective is the EP provides patients with timely electronic access to their health information and patient-specific education. There are two measures for this objective, and EP must satisfy both measures through a combination of meeting the thresholds and exclusions. Measure 1. For more than 80% of all unique patients seen by the EP, the patient is provided timely access to view online, download, and transmit his or her health information. And the provider ensures the PHI is available for the patient access using any application of their choice that is configured to meet the technical specifications of the Application Programming Interface, or otherwise known as API, in the provider's CEHRT. Measure 2. The EP must use clinically relevant information from CEHRT to identify patient-specific educational resources and provide electronic access to those materials to more than 35% of unique patients seen by the EP during the PI reporting period. The exclusions for measures 1 and 2. Both measures have the same exclusions. The first exclusion that is available for measures 1 and 2 is the EP has no office visits during the PI reporting period. The second exclusion that is available for measures 1 and 2 is the EP conducts 50% or more of his or her patient encounters in a county that does not have 50% or more of its housing units with 4 megabytes per second broadband availability according to the latest information available from the Federal Communications Commission on the first day of the PI reporting period. We call this second exclusion the broadband exclusion. For program years 2015 through 2017, CMS identified the counties in the U.S. who conducted 50% or more patient encounters in a county where 50% or more of its housing units do not have 4 megabytes per second broadband availability and therefore meet the broadband exclusion. The state of Arizona does not have any counties listed, therefore an EP in Arizona is not able to meet this exclusion. CMS has not published an updated list of the counties. However, the majority of counties in the U.S. have increased their broadband availability and still do not meet the requirements for the exclusion. It is unlikely the broadband availability would have decreased since the CMS tip sheet was published. The link at the bottom of this slide will take you to that CMS tip sheet if you want to review it on your own. Documentation for this objective. The percentage-based standard documentation is required, and you can look at slide 17 to see the details of the documentation. Additional documentation is required for this measure objective. To determine the documentation necessary to support meeting this measure, click the link below, which takes you to the Patient Electronic Access webinar, which walks you through and describes the additional documentation that will be required from EPs. The exclusion documentation. So keep in mind that there are 2 exclusions, and they fall under both measures 1 and 2. The first exclusion is the EP has no office visits during the PI reporting period. Additional documentation will be required if the EP attests to this exclusion. The EP must submit documentation to show the place of service code for all encounters during the PI reporting period. The broadband access exclusion is not available to Arizona EPs. And there is the link again to go and look at the CMS tip sheet for broadband access exclusion. For Objective 6, Coordination of Care. The objective is to use the CEHRT to engage with patients or their authorized representatives about the patient's care. Measure 1. More than 5% of all unique patients seen by the EP actively engage with the EHR made accessible by the EP, and either 1, they view, download, or transmit to a third party their health information, or 2, access their health information through the use of an application programming interface that can be used by applications chosen by the patient and configured to the API in the EP CEHRT. Or there's a third option to meet this measure. The EP can do a combination of 1 and 2. So they can have patients view, download, or transmit, and then they can also use API to help meet that. Measure 2. For more than 5% of all unique patients seen by the EP during the PI reporting period, a secure message was sent using the electronic messaging function of CEHRT to the patient, or in response to a secure message sent by the patient or their authorized representative. Measure 3. Patient-generated health data or data from a non-clinical setting is incorporated into the CEHRT for more than 5% of all unique patients seen by the EP during the PI reporting period. An EP must meet the minimum threshold for 2 of the 3 measures or meet 1 of the 2 available exclusions. The exclusions for all 3 measures are the same. If the EP meets 1 of the exclusions, they can meet the exclusion for all 3 measures. At the bottom of the slide are some examples of possible combinations to help the EPs meet the measures. As you can see in the far left column, it identifies whether the EP passes or fails depending on the different measures. So for the first example, the EP is passing because for measures 1 and 2, they meet the threshold, and then for measure 3, the EP does not meet the threshold. The requirement for this objective is that an EP must meet the minimum threshold for 2 of the 3 measures. So they met measures 1 and 2. On the next line, you can see that they met the threshold for measure 1, and they took the exclusions for measures 2 and 3. The EP will also pass in the third example where they took the exclusion for all 3 measures. The last example, the EP is failing because the EP does not meet the threshold or the exclusions for any of the measures. Please keep in mind that any of these combinations that are attested to, you will need to submit documentation to support your attestation. The exclusions for coordination of care. Measures 1, 2, and 3. An EP may take the exclusion if either of the following apply. There's 2 exclusions that meet all 3 measures. The EP has no office visits during the PI reporting period. And the second exclusion is the broadband access exclusion previously discussed under Objective 6 and is not applicable to Arizona. The documentation requirements for coordination of care. The measure documentation that is going to be required is the percentage-based standard documentation, and you can see slide 17 for the specifics of what needs to be shown for the standard documentation. Additional documentation is required. The EP needs to explain what patient-generated health data is being utilized and how the CEHRT is capturing that data. The exclusion documentation. The first exclusion is the EP has no office visits during the PI reporting period. To meet this exclusion, additional documentation must be submitted showing the place of service code for all encounters during the PI reporting period. The second exclusion is the broadband access exclusion, and it does not apply to EPs in Arizona. Objective 7, health information exchange. The objective is that the EP provides a summary of care record when transitioning or referring their patient to another setting of care. Receive or retrieve a summary of care record upon the receipt of a transition or referral or upon the first patient encounter with a new patient, and incorporate summary of care information from other providers into their EHR using the functions of a CEHRT. Measure 1 underneath this objective is for more than 50% of transitions of care and referrals. The EP that transitions or refers their patients to another setting of care or provider of care and creates a summary of record using the CEHRT and electronically exchanges the summary of care record. For measure 2, an EP must have for more than 40% of transitions or referrals received and patient encounters in which the EP has never before encountered the patient. He or she incorporates into the patient's EHR electronic summary of care document. For measure 3, as you can see, the percentage changes for more than 80% of transitions or referrals received and patient encounters in which the EP has never before encountered the patient. He or she performs a clinical information reconciliation. The EP must implement clinical information reconciliation for the following 3 clinical information sets. 1, medication. Review of the patient's medication, including the name, dosage, frequency, and route of each medication. 2, medication allergy. Review of the patient's known medication allergies. And 3, the current problem list. Review of the patient's current and active diagnoses. An EP must meet the minimum thresholds for 2 of the 3 measures. If the EP meets the criteria for exclusion from 2 measures, they must meet the threshold for the 1 remaining measure. If they meet the criteria for exclusion from all 3 measures, they may be excluded from meeting this objective. And then there are some examples of possible combinations. As you can see in that far left column, it does identify whether the EP passes or fails, and then it shows what they attested for measures 1, 2, and 3. For the first 3 examples, you see the EP is passing because they either meet the threshold of 2 or they took the exclusion for all 3 measures. As you can see on the 4th row, the last pass, it says the EP meets the exclusion for 1, 2, and 3. Therefore, they can meet that objective, or they're excluded from meeting the objective. For the next example, second to the bottom, it shows the EP is failing because the EP meets the exclusion for measure 1, meets the threshold for 2. However, the EP does not meet the threshold or exclusion for measure 3. The EP is not, once they take the exclusion for 1 measure, they must either meet the threshold or exclusion for the other 2 measures. The last example is the EP fails because the EP meets the exclusion for measures 1 and 2, but does not meet the threshold or exclusion for measure 3. Please keep in mind these are just a few examples of the different scenarios EPs can fall into, but they can change depending on which measures they meet and which measures they take exclusions to. These are not a complete set of all combinations. An EP may take an exclusion if the EP meets the exclusion criteria applicable to the measure in the table below. For measure 1, an EP transfers a patient to another setting or refers a patient to another provider fewer than 100 times during the PI reporting period. If the EP meets that exclusion, they can exclude from measure 1. For measures 1 and 2, an EP conducts 50% or more of his or her patient encounters in a county that does not have 50% or more of its housing units with 4 megabytes per second broadband availability. Please keep in mind that this is the broadband access exclusion previously discussed and is not applicable to Arizona EPs. You cannot take this exclusion for measures 1 and 2 in Arizona. For measures 2 and 3, the total transitions or referrals received and patient encounters in which the EP has never before encountered the patient is fewer than 100 times during the PI reporting period. That exclusion can help the EP take the exclusion for measures 2 and 3. Let's discuss the documentation required. The percentage-based standard documentation is required, and you can look at slide 17 to see what requirements should be showing on the standard documentation. If an EP meets the exclusion or attests to meeting the exclusion, for any of these exclusions, they have to submit the appropriate documentation. For exclusion, EP transfers a patient to another setting or refers a patient to another provider fewer than 100 times. This is only for measure 1. The total transitions or referrals received in patient encounters in which EP has never before encountered the patient is fewer than 100. That exclusion is applicable for measures 2 and 3. The standard documentation is an option to be submitted. It's the CEHRT dashboard showing that the EP had fewer than 100 qualifying transitions, referrals, or encounters for the appropriate measure during the PI reporting period. Or the EP can submit alternate documentation, which is not the CEHRT dashboard, and it shows the EP had fewer than 100 transitions, referrals, or encounters for the appropriate measure. The EP should submit either the standard documentation or the alternate documentation if claiming exclusions for any of the measures. The last exclusion that is possible is the broadband access exclusion, which applies to measures 1 and 2. However, it does not apply to Arizona EPs. Objective 8, public health reporting. The EP is in active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using certified electronic health record technology, except where prohibited and in accordance with applicable law and practice. An EP must satisfy 2 of the 5 available measures for this objective. If an EP cannot satisfy at least 2 measures, they may still meet the objective if they qualify for exclusion from all measures they cannot meet. Measure 1, immunization registry reporting. The EP is in active engagement with a public health agency to submit immunization data and receive immunization forecasts and histories from the Public Health Immunization Registry or Immunization Information System. Measure 2 is syndromic surveillance reporting. The EP is in active engagement with a public health agency to submit syndromic surveillance data. Measure 3 is electronic case reporting. The EP is in active engagement with a public health agency to submit case reporting of reportable conditions. Measure 4, public health registry reporting. The EP is in active engagement with a public health agency to submit data to public health registries. Measure 5, clinical data registry reporting. The EP is in active engagement to submit data to a clinical data registry. An exclusion for a measure does not count towards the total of 2 measures. In order to meet this objective, an EP needs to meet 2 of the total number of measures available to them. If the EP qualifies for multiple exclusions and the remaining number of available measures is less than 2, the EP can meet the objective by meeting all of the remaining available measures and claiming the applicable exclusions. Available measures are ones for which the EP does not qualify for an exclusion. So exclusion 1. The EP does not operate or is not required to operate or operates in a jurisdiction where the applicable data is not collected by that jurisdiction's registry. Specifically, for each of these measures, for measure 1, the EP does not administer immunizations to any of the populations for which data is collected. This exclusion 1 applies to measure 2 as well, if the EP is not in a category of providers from which ambulatory syndromic surveillance data is collected. Measure 3, the EP does not diagnose or directly treat any reportable diseases for which data is collected. Measure 4, the EP does not diagnose or directly treat any disease or condition associated with a public health registry. Measure 5, the EP does not diagnose or directly treat any disease or condition associated with a CDR. Exclusion 2, which applies to all 5 measures. The appropriate exclusion can be claimed if at the start of the PI reporting period the EP practices in a jurisdiction for which measure 1, no immunization registry, is capable of accepting the specific standards required to meet the CEHRT definition. For measure 2, no public health agency is capable of receiving electronic syndromic surveillance data in the specific standards required to meet the CEHRT definition. Measure 3, no public health agency is capable of receiving electronic case reporting data in a specific standards required to meet the CEHRT definition. Measure 4, no public health agency is capable of accepting electronic registry transactions in the specific standards required to meet the CEHRT definition. And then for measure 5, no CDR is capable of accepting electronic registry transactions in the specific standards required to meet the CEHRT definition. As you can see, exclusion 2 is the same across the board. It just relates to the different agencies or registries underneath each measure. Exclusion 3, which applies to all 5 measures. The appropriate exclusion can be claimed if 6 months prior to the PI reporting period, the EP practices in a jurisdiction where, for measure 1, no immunization registry has declared readiness to receive immunization data. Measure 2, no public health agency has declared readiness to receive the appropriate data. For measure 3, no public health agency has declared readiness to receive electronic case reporting. For measure 4, the exclusion can be taken if no public health agency for which the EP is eligible to submit data has declared readiness to receive electronic registry transactions. And for measure 5, no CDR for which the EP is eligible to submit data has declared readiness to receive electronic registry transactions. Please note, when jurisdiction is mentioned throughout any of these slides, it is general and the scope may be at the local, state, regional, or national level. So the documentation for this objective. Yes, no standard documentation for each measure will be required, and you can look back at slide 18. Examples of supporting documentation to meet this measure are included in the documentation retention webinar. So if you want to make sure that you collect the correct documentation and submit it during attestation, we highly suggest you go to the documentation retention webinar and look at the examples in that webinar. For exclusion documentation, additional documentation for exclusion 1 will be requested. The EP will need to explain and document why they are not required to collect the data for the applicable measure in their jurisdiction. Depending on that exclusion 1, because it applies to all 5 measures, you need to explain for each measure why the EP meets that. Additional documentation for exclusions 2 and 3 will also be required. An EP must complete 2 actions in order to find available registries or claim an exclusion. The first requirement is the EP needs to determine whether his or her jurisdiction endorses or sponsors a registry. And when you go and try to determine that, try to document the steps that you take. And 2, determine whether a national specialty society or other specialty society with which he or she is affiliated endorses or sponsors a registry. So you must follow both those steps. For example, if you send an email to the cancer or your pediatrician, and you send an email to the pediatric specialized registry and ask them if they're accepting data, documenting that and keeping that email for your records would be sufficient and needs to be uploaded during attestation. So a reminder, in addition to meeting the ME requirements discussed throughout this presentation, the EP must meet all eligibility requirements of the program, including the minimum Medicaid and/or needy patient volume. To learn about those eligibility requirements, you can use the documentation retention link. Please keep in mind for patient volume, the reporting period for program year 2019 is any continuous 90-day period between January 1st, 2018 and December 31st, 2018. We're going to discuss audit findings briefly. So what happens during an audit? All providers that receive a Medicaid PI incentive payment could potentially be selected by Access for post-payment audit. If selected, Access post-payment analysts will conduct a thorough review of the documentation attached to the EP's attestation and EPIP to determine if it meets the program requirements. Access may have follow-up questions or make additional documentation requests. Some common audit findings: failure to provide sufficient documentation for protecting electronic health information. The CEHRT dashboard does not show the PI reporting period or EP name. Failure to maintain proper documentation and practice no longer has access to the CEHRT. Supporting documentation does not have the appropriate dates. And the last common audit finding is including data for the entire practice in the reported CEHRT report rather than data for the individual EP. Please keep in mind these are not the only audit findings. They're just some of the more common ones. I know this was a lot of information, so there is a lot of resources at the end of this presentation, as you can see. There are different webinars mentioned throughout the presentation, and they are all listed on this slide. So if you want additional details regarding any of these objectives that were discussed, you can open up each of these webinars and look at the different ones to see what information is out there. Please keep in mind that we will be doing additional webinars throughout this year, and that other objectives will be discussed in depth on those webinars, and those dates will be sent out as they are determined. Okay, are there any questions?
The chat box is open. I have not had any questions come through. We can pause here and let folks have an opportunity to type those questions in. I am also, would you like all the phone lines open as well?
Yes, that would work. And then people can speak out loud if they need to.
Okay, we're going to go ahead and open up all the phone lines. If you are not speaking, please keep your line on mute so the background noise doesn't come through. So we'll go through that process. Again, you can still use the chat box if you would like to type your questions at this time for Priscilla. Getting some feedback there.
If we want, we can turn off the lines, and then if you have any questions or if you want to be unmuted, Christine.
Oh my God.
If you request that in the box. And what I'll do is I will go over, we did put together a presentation for frequently asked questions. I will walk through some of those questions. Maybe if it brings anything to mind, please interrupt me, Christine or Connie, if anyone puts any questions in the chat box. And we only have a few minutes left, and please keep in mind that this was a lot of information. The presentation and this frequently asked question document will be put on the Access and Health Current website. If you have additional questions at that time, you can reach out to Access, and they will get to your question as quickly as possible.
Yes, just a reminder to everybody, a copy of today's webinar presentation, both the recorded and the slide deck, along with the FAQs, will be sent out to those that are participating. So, good question that came through. Just a reminder, we did have to go back and mute all the lines again due to some feedback. So I will turn it back over to you, Priscilla. And again, the chat box is open, and questions coming through, we'll go ahead and ask those. Thank you.
Thanks, Christine. So we're just going to go over this frequently asked question document. I'm going to just go through a few of the questions while we have some time left, and you do put one of your questions in the chat box, I will pause and answer that question as it is a priority. So we're going to go over questions 3, 4, and 5, which is the different reporting periods and how they apply to each of the requirements. So for question 3, it says, are EPs required to meet the patient volume requirements for program year 2019? The answer is yes. The EP should select a 90-day patient volume period within calendar year 2018. And the EP must have either greater than or equal to 30% Medicaid patient volume or greater than or equal to 30% needy patient volume if practicing predominantly at an FQHC or RHC. Please keep in mind if you're a pediatrician, your minimum threshold can be 20%. However, it would come with a reduced payment through the program. Question 4, how long is the PI reporting period supposed to be for 2019? The PI reporting period in program year 2019 is 90 days regardless of the MU payment year. For question 5, how long is the ECQM reporting period for program year 2019? The ECQM reporting period in program year 2019 is 90 days for EPs attesting to their first year of MU. The ECQM reporting period is 365 days for EPs that have received an MU payment in a previous year. I'm going to skip down to a few other questions that may be more important. It asks, what is the percentage-based standard documentation? It is a CEHRT dashboard covering the entire PI reporting period that reflects the correct PI reporting period on it. It includes the provider name, it reflects all percentage-based measures, and it matches the attestation. If the EP is attesting to an exclusion for a measure, the CEHRT dashboard may be utilized to support meeting the exclusion criteria for certain measures. If the exclusion is not supported by the CEHRT dashboard, additional documentation is required. Should the EP run the CEHRT dashboard for all percentage-based measures based on the practice or the individual? The EP must attest to meaningful use based on his or her individual data, the numerator and denominators. Therefore, the CEHRT dashboard submitted should demonstrate the EP's individual numerators and denominators for each measure rather than the data for the practice. Which locations should be included in the reported numerators and denominators? The reported numerator and denominators should include the EP's data from all CEHRT locations. For example, if the EP worked at 3 locations using CEHRT, all 3 CEHRT dashboard reports, one from each location, should be used to calculate a combined numerator and denominator for each measure. Each CEHRT dashboard used to complete the attestation should be uploaded in EPIS. Okay. And if there are no other questions in the chat box, I'm going to continue reading these. What place of service codes should be included in the CEHRT dashboard? The answer is the tested numerator and denominator should be comprised of the number of patients seen in the outpatient setting, since this setting is where the EP is eligible to receive PI incentive payments. For example, if an EP has patients in both the inpatient and outpatient setting, so in a hospital and clinic, and where CEHRT is available at each location, only the patients seen at the clinic should be included in the CEHRT dashboard. Okay. Question 16, what is the yes-no standard documentation? The yes-no standard documentation should show that it includes the provider and or practice name, it should reflect results for the measure, it should be clearly legible, and it should reflect the date the requirement was met. The CEHRT dashboard alone cannot be used to support these measures. Documentation could include screenshots from the CEHRT or vendor letters to support the applicable functionalities were enabled or the actions required were performed. Question 17 is extremely important because it talks about the dates for the different yes-no documentation and what the appropriate date is. The appropriate date of the supporting documentation varies depending on the yes-no measure. For security risk analysis, the SRA must be completed on or after the end of the PI reporting period and no later than December 31st, 2019, because this is applicable to program year 2019. This entire presentation is applied to program year 2019. Clinical decision support rules and drug and drug allergy interaction checks. The documentation submitted for that should reflect a date the requirement was met during the PI reporting period. You must show that CDS and drug was met during that 90-day PI reporting period that you attested to. For public health measures, the documentation should reflect a date within 60 days of the start of the PI reporting period. The documentation should reflect the date the requirements were met. For example, if submitting a screenshot, capture the date of the screenshot was taken. Usually that screenshot's going to show in the bottom right-hand corner of your screen. It's going to have the date, and you want to make sure that's included in the screenshot. Okay, we have a few minutes left. If you have any questions you want to ask, please go ahead and put that in the chat box. Okay, question 19. When must an SRA be completed to be sufficient? We just went over this. It must be completed on or after the end of the PI reporting period. It cannot be completed during the reporting period. It can be started during the reporting period, but you must complete it on or after the end of the PI reporting period and no later than December 31st, 2019. And the date should show in the documentation the date it was completed. Okay, what should the documentation show to reflect that CDS rules were enabled during the PI reporting period? The documentation should show that 5 CDS rules related to 4 or more CQMs were enabled for the entire PI reporting period. For example, screenshots from the CEHRT showing the 5 different CDS rules were enabled during the PI reporting period. Again, when taking screenshots, capture the date on your computer screen, usually located in the bottom right-hand corner. Please keep in mind, for 5 CDS rules, you need to show the 5 specific CDS rules that were turned on. You can't just show one CDS rule related to a CQM measure and think that's sufficient. You need to make sure you screenshot all 5 of those CDS rules being turned on during the PI reporting period. Okay, question 21. What should the documentation show to reflect that drug and drug allergy interaction checks were enabled during the PI reporting period? The documentation should show that drug and drug allergy interaction checks were enabled for the entire PI reporting period. For example, screenshots from the CEHRT showing that the drug and drug allergy interaction checks were enabled during the PI reporting period, and make sure that screenshot has a date on it. So, Christine, Connie, are there any other questions that have come through?
No, there have been no questions in the chat box yet.
Okay.
And we are at the top of the hour. Did you want to have any final FAQs that you wanted to go through, or?
I think we're good on my end. Again, everyone, just keep in mind, there was a lot of information, and the webinar and the FAQ will be made available to you on Access and Health Current website.
Yes, that is correct. Thank you again for those that had posed questions and comments. Again, just a reminder that today's webinar has been recorded, and we'll be sending out a copy of the slide deck and the frequently asked questions during the call. Again, the chat box has not had anything additional come through, so this will conclude today's webinar. Thank you to Access for your presentation today. Thank you for all that have been participating. Have a wonderful rest of your day. Thank you very much.